warm welcome to all of you on behalf of Cornea Society of India. I would like to welcome all the speakers. I would like to welcome our panelist, Dr. Nikhil Gokhale, my partner in crime, Vikas, and all the attendees who are sitting there. Hopefully, you're sitting for our session and we will not disappoint you. The session is meant for general ophthalmologists. So basically, all our speakers are very good in their own subject, and they have carved up a course which sort of would help our general ophthalmologists in their day-to-day activity. The plan is that every speaker would have 10 minutes talk, and then which will be followed by a couple of minutes of presentation. I would request all the speakers to be on time so that we can finish it on time, and maybe we can meet up those celebrity out there who's inaugurating in some other hall. But hopefully we have better celebrities here who are no less than that. We start our first thing, and I would request Vikas to introduce our first speaker.
Our first speaker is Dr. Ahmedita. She's there? Okay. So, Ahmedita is from Cornea and Ear Segment Services, L.U. Prasad Eye Institute, Vijayawada, and she's going to talk about allergic eye diseases. Over to you, Ahmedita.
Thank you, Dr. Vikas. So, good evening, everyone. Today I'll be discussing the management of uncontrolled allergic eye disease. As we know, ocular allergy can present to us in different ways, and there are several therapeutic options available out there for the management of these cases. Because of this, what happens is that when we have a patient in our OPD who is not responding to therapy the way we expect them to, we are often posed with the question, what is the next best course of therapy for this particular case? So this is even made complicated by the fact that there's so many options available out there. So how do we handle such cases? The first step is to classify the disease based on the periodicity and the severity. Let me take you through what these terms mean. A patient is considered to have an intermittent disease if the inflammation-free intervals are there of at least 2 to 3 months after discontinuing the topical therapy. And if the patient has a relapse within 1 month of stopping the anti-allergic medications, then the patient is said to have a chronic disease. Now, when we are trying to decide if the patient has an intermittent or a chronic disease, we have to obtain a very thorough past history, especially in terms of prior use of steroid and what was the response to this. So basically, we need to ask the patient if they have used steroids, whether they were symptomatically better with them, and once they stopped, how quickly did they relapse. So this will give us a fairly good idea if the disease is intermittent or chronic in nature. So next, coming to the classification of the severity. So this is a classification that was proposed that classified ocular allergy into mild, moderate, severe, and blinding. The disease is considered mild if the patient has only symptoms with a few papillae. It is moderate if the patient has up to 6 clock hours of limbal involvement with limbal inflammation, horn or tranta spots, or very fine SPKs. If this progresses to annular involvement of the limbus, or if there are coarse macroerosions, as can be seen over here, because of giant papillae, then the disease is considered to be severe. And if this progresses until the patient develops total limbal stem cell deficiency, or if the patient has a very severe shield ulcer with scarring, then it is blinding. So is it sufficient just to rely on clinical signs to decide whether the patient has an uncontrolled disease or not? Very frequently, we will see such a case in our OPD where the patient has diffuse dispersion of pigment over the surface, minimal surface inflammation, and a few papillae. So in these cases, it is very important to, again, go back to the history and ask the patient if if they're symptomatically better. So if the patient says that a couple of months ago, I was symptomatically worse, and after using the medications, I'm feeling better, even with this type of a surface, it is not an uncontrolled disease, because in such severe cases, even when the disease is quiescent, the ocular surface may not come back to normal. So let us see now how to manage these cases. When the patient has a chronic disease with mild or moderate severity, in the acute phase, the usual armamentarium of drugs is used. The patient is started on a course of soft steroids with either loteprednol or fluoromethalone. And in addition to this, antihistaminics and mast cell stabilizers are also used. These are the commonly used medications. Mast cell stabilizers, they take some time for the onset of action. They take around 2 to 4 weeks, whereas the lower group of drugs, which are dual acting, have a faster onset of action. Because the disease is chronic in nature, the patient will require a maintenance therapy, either in the form of topical steroids, low dose, every alternate day or once in 2-3 days, or the patient can be placed on topical immunosuppressants with cyclosporin and tacrolimus. Both are calcineurin inhibitors and they inhibit the effect of T cells. These are the concentrations in which the drugs are available. Again, these medications, they also take around 4 to 6 weeks for their onset of action, and so they have to be combined with topical steroids when they're initially given. Irrespective of the, there are several studies which have looked into the efficacy and they have established the safety and efficacy of these medications, and comparative trials have not found any difference between cyclosporin and tacrolimus in the use for VKC. So irrespective of the severity of the disease, patient counseling is a very integral part in the management of ocular allergy. The patients have to be counseled regarding the chronic course of the disease. They have to be explained that this is a disease where there will be a relapse, so that they don't get alarmed and visit a different doctor every time. Otherwise, what will happen, they will get overtreated with steroids, and then we will have to deal with the slew of complications that is associated with steroid use. And avoiding eye rubbing cannot be overemphasized, because this is also plays a very important role in the pathogenesis of the disease, and patients have to be counseled that if they have the urge to itch, they can use cold compresses instead. So coming to the management of severe or blinding disease, in these cases in the acute phase, potent topical steroids, prednisolone acetate 1% in a tapering dose is administered. And again, they will also require maintenance either with topical or oral immunosuppressants. So typically, topical immunosuppressants with cyclosporin or tacrolimus are preferred. Oral immunosuppressants are given to those patients who have a very severe disease, which is also chronic in nature, or the patient also has associated systemic allergy. So the commonly preferred systemic immunosuppressive agents include oral steroids, cyclosporin, omalizumab, which is a monoclonal anti-IgE antibody, which is injected subcutaneously. So this was a patient who presented to us, a 15-year-old child with severe papillae, giant papillae, and the child gave history of being on and off steroids for 9 years. And the patient was started on a combination therapy of oral steroids and oral cyclosporin in addition to topical therapy. And after 3 months of this combination therapy, a dramatic response was seen to the oral immunosuppressants. This similar response has also been reported in literature, both with combination therapy and cyclosporin in isolation, as seen in this case, which is a case of atopic keratoconjunctivitis, which was also treated with a combination of oral steroids and cyclosporin. Blinding disease, in addition to the topical therapy and systemic therapy, also requires surgical therapy. So in the papillary variant, where there are giant papillae, supratarsal steroids are administered, or in, again, very severe cases, shave excision with conjunctival autograft and mucous membrane grafting can also be done. When there is limbal stem cell deficiency, the treatment of choice is limbal stem cell transplant. So a little bit more about supratarsal steroids. So several studies have shown that the actual medication, all 3 drugs have a very similar onset of action, and within 3 weeks there is resolution of the shield ulcers that is seen. However, it is very important to note that when supratarsal steroids are given in isolation, there is a recurrence of the disease within 6 months, which goes back to its original severity. So the point to be taken here is that supratarsal steroids, even when they are given, in addition to that, topical and systemic immunosuppression should be given to the patient. Before I conclude, I'll just add a short note on immunological tests. Now, these are very well established in systemic allergy. In ocular allergy, their role is still being explored. Both in vitro and in vivo tests are available. Total IgE can be done, however, it is non-specific. Serum IgE for a specific allergen is also being carried out. So here, this was a 14-year-old patient who had uncontrolled VKC and allergic rhinitis. Her total IG was it was elevated. You can see it's almost 600, whereas the normal for that age is less than 200. So we went ahead and carried out a allergen-specific IgE. Now, the type of allergen depends upon what is the most common allergen in that geographic area, and this is the panel that is available in our geographical area. So here you can see the patient had sensitivity to these agents. And so once the agent is identified, we counsel the patient to avoid them. This has also, again, been reported in literature where complete resolution of the signs was seen once the allergen was avoided, and this way, administration of either topical or systemic immunosuppression can be avoided in these cases. So the in vivo tests include skin prick and patch tests, which also work on the same principle where the allergen is inoculated in the skin and the wheal and the flare is measured, and the allergen that the patient is sensitive to can be identified this way. So in conclusion, patient counseling is one of the most important parts of managing an uncontrolled ocular allergy. They have to be counseled regarding avoiding eye rubbing as well as the chronic nature of the disease. Maintenance therapy for patients who have chronic, mild to moderate disease is needed after the acute phase resolves. This can be given with either topical steroids or topical tacrolimus or cyclosporin. Systemic therapy is reserved for those patients who have a very severe disease, which is also chronic, or they have associated systemic allergy as well. Thank you, everyone, for your patient listening.
Thank you, Anahita. That was really nice, and you covered up most of the things which a general ophthalmologist would wonder. I just have one question. Now that we have so many molecules which you showed that you can give any of the antihistaminics or anti-allergic molecules, how do you decide in your clinical practice where do you start with? What is the steroid which you start with, and what is the anti-allergic molecule which you start with?
So again, depending upon the severity, if the patient has a moderate disease, I will start with Cromalfort, 4%. And with this, I give loteprednol. I start at around 6 times and taper it slowly over 6 to 8 weeks. If the patient gives history that he keeps having recurrent attacks, I will add topical tacrolimus ointment once at night. And if the patient has a very severe disease, then my drug of choice would be prednisolone acetate right from the get-go.
So, Anahita, can I ask one question, please? For that article or the database that you have shown, so in shield ulcer or severe where you have a giant papilla also, did you see a comparison between supratarsal Kennicott vis-a-vis systemic steroids?
No.
Okay. So that Himanshu or Dr. Maskati, somebody want to, or Dr. Nikhil? So my question is that supratarsal Kennicott vis-a-vis systemic steroids.
So actually, I think if you have severe tarsal disease, many of the times these children have shield ulcers, and we need to debride. So the clinical situation whereby I often use supratarsal steroid is when there is a child with uncontrolled VKC, with cobblestones, with a shield ulcer which needs debridement. So I need to give them some sort of anesthesia and debride the ulcer. At that time, I would try to give a supratarsal steroid. Systemic steroid probably may not be required if the local steroid works. Of course, the steroid response, we may say that we will watch the IOP, but again, it's quite a difficult job. So that is something we have to keep in mind. But if you have very severe disease, then probably systemic steroid will work better, faster probably. But
yeah, I very rarely would start systemic steroids. I do a lot of I rely a lot on cyclosporins. So both the orosporin drops, which are burning and stinging, yes, and the tacrolimus ointment, which can be given through the skin or into the eye. If there's a lot of irritation in the eye, there are people who, many countries of course don't even have the eye ointment, so they have to use the skin ointment outside. Seems to work. So all this has lessened our dependence on systemic steroids, at least to a large extent. Other simple lid hygiene measures also do tend to help, simple cold compresses and things which I think are underestimated in our treatment regime.
I can also recollect that, I've had instances of refractory shield ulcers that I have given supratarsal steroid, given topical steroid, anti-inflammatory, and, it just fails to resolve, and then I had to resort to maybe oral steroid for a short period of time, and then probably they healed faster.
So I have one question for the panelists as well as you, Anahita, that an allergic eye disease, or rather allergy of any form, is not a disease of the effect what we are seeing. That's the effective part which we are seeing, the immune part of it. But that's not the root cause, right? So when we are not treating the root cause, what are we expecting? We are expecting a natural desensitization which would occur naturally in many of them. So with the presence of now the sublingual immune therapy, do you think there is a role that we can more often refer to the immunologist these allergic eye disease patient, or well, we don't need to go that level?
So again, practically, if we have patients who can be managed safely with local treatment and they're doing quite okay, probably I may not refer them, all of them. But when we come to a situation where the disease is refractory, or we need exceedingly higher doses of steroid, or we need a therapy which seems frightening to us personally, I think in those situations, 100% try desensitization, allergy testing, and so that possibly we can reduce the pharmacotherapy that is required to control the disease.
Yeah, I think I have nothing more to add. I would entirely agree with Nikhil that we would use these measures where we have to refer to our rheumatologist colleagues or your physician colleagues only as a last resort. Almost 95% of the patients we are able to manage and still keep them off steroids and safe.
The other thing we need to remember is the desensitization therapy also takes several years to take effect. So we cannot expect quick results. It might take 3 or 4 or even 5 years for the effect to be there. So it's a parallel treatment that can be continued. Just like sometimes somebody will say, I'll take homeopathy, we don't refuse it, but we need to do what is required for our control.
The compliance with these therapies is quite low. I used to refer a lot of patients for the allergy testing and then the desensitization injections. But most parents dropped out because of the multiple times that they had to visit and get the injections done. So we seldom use it. Yes, you had a question.
Sir, I just wanted to add something in the doing skin prick test in the allergic conjunctivitis patient. There is a study published in an allergy journal. Kids who has taken oral immunotherapy or sublingual immunotherapy, these kids are less prone to go in asthma in adulthood. So if you treat these patients at that stage with the systemic, with allergy testing and immunotherapy, we can prevent the allergy march also. So even though patient will be in a quiet stage afterwards, but after a few years, he or she may go in a other systemic allergic disease, and that desensitization helps to prevent such kids to go in other systemic complication of allergy. That study has been published. And second thing about the what sir has mentioned, for the allergy shots, patient has to visit frequently. But sublingual immunotherapy is a good choice for that, because patient no need to visit every time for the injection in the hospital. 1 month, 2 months or 3 months, as we are practicing in allergy, we are doing desensitization and immunotherapy. So we can send it with courier also, so that or 3 monthly we can analyze such patients. So with sublingual, we can manage that follow-up problem also.
Thank you. I think we'll move on. Thank you, Anahita. So we have our next speaker, Dr. Priya Desai. She is the director of Desai Group of Eye Hospital, Vadodara, and she's a young cornea refractive surgeon. Priya is going to talk to us about Desmond membrane detachment. Over to you, Priya.
Thank you, Dr. Himanshu. I think the slides are not being projected. Yeah, okay. So, thank you very much, and good evening, everyone. Now, Desmond's membrane detachment, as I would like to call it, as Desmond membrane curls. DM detachment is basically a complication usually faced after surgery. A detached Descemet's membrane can be diagnosed on slit lamp examination as a clear optical space between the stroma and the Descemet's membrane. So now, how do you classify these curls? So it's a very beautiful classification given that what are the things that you can see the next day if you have had a complication after your cataract surgery or your trab or whatever surgery you're doing. You can see Descemet's folds, you can have a Descemet's detachment. Now we further classify Descemet's detachment into rhegmatogenous, bullous, tractional, and complex. I will be covering each of these after the slides. And after, you can even have a loss of Descemet's and a post-endothelial keratoplasty surgery. So rhegmatogenous DM detachment. It's usually seen when there is a break in DM. There is a fluid accumulation between the DM and the stroma. It can also occur secondary to a hole or a tear during insertion of blunt instruments. Also seen as a detachment from Schwalbe's line during trabeculectomy. Clinically, it is seen as an undulating membrane in the anterior chamber. And on an OCT, it is seen as an undulating hyperechoic membrane. So at this point in time, I would like to highlight that certain diagnostic tests are very important. Like, for example, in a DM detachment, if you have an access to an OCT, your things become much easier. And I always believe that diagnostic tests should not be a supplement to your clinical exam. It should be, it should not be a substitution. It should be a supplementation. So only if you cannot figure out clinically whether it's a DM detachment or a fold or a DM loss, ASOCT, I think, probably is a golden tool which is going to help you to decide on what further management you would want to do for your patient. Tractional DM, so if you see the previous slide, you can see the Descemet's as a curl or a fold, and there is free space between. But if you see a tractional Descemet's detachment, it's very taut. It's like a tight membrane that you can see. Usually secondary to inflammation, trauma, surgery. There's fibrosis, peripheral synechia, subsequent contraction. And it's taut, it's like a tempolin, and there's no movement on BSS injection. On an ASOCT, the arc length of the cornea is more than the DM. In bullous, it's exactly the opposite. It can be because of a disease process, infection, or inflammation, and it's seen as a convex membrane bulging in the anterior chamber. And in complex, you can have a mixture of all of these. So though we're talking about Descemet's detachment, why am I insisting on showing you DM folds? Because there are a lot of times we can mistake DM folds and DM detachment, and the management of both is completely different. So how do you see DM folds? DM folds are folds that are visualized like crisscross lines in the posterior stroma and DM associated with hazy or mild loss of corneal transparency. And it can be because of endothelial cell loss, intraocular manipulation, mechanical trauma. And management is usually wait and watch. You wait for the inflammation to subside. You try to evaluate of how you would have probably done this, and topical corticosteroids help to reduce the inflammation. So if you have a if you have DM folds instead of a detachment, you don't have to intervene. You have to wait for the inflammation to go down. And the third is DM loss. So, probably when you're going through your side port, there is a part of DM that you have lost during the surgery. It can be seen while you're using blunt instruments. And the management of a DM loss is very different. If you have a very small DM detachment, which is not in the visual axis, which is not very significant, there's no edema, the visual axis is clear, the patient is not complaining, I think you can wait and watch. And obviously, if it is significant, then you can do an endothelial keratoplasty. After a post-DMEC surgery or a Desect surgery, when you have your lenticule which is not attached properly, this is the kind of picture you see. So Jacob et al. Have classified DM detachment very beautifully. If you have a rhegmatogenous detachment, it can be secondary to a hole, tear, or dialysis. If it is insignificant, observe the patient. If it is significant, do an air injection, drain the fluid, give the patient a position, and wait for, and keep on following up the patient and wait for it. If you have a bullous detachment, it can be because of hydroseparation, viscoseparation, iatrogenic. Observe the patient, and if you feel that the inflammation has gone down, but the detachment is, the Descemet's is not reattaching, you can probably do a relaxing desmetotomy and inject air and give the patient position. Tractional can be because of incarceration in synechia, long-standing vitreous strands adhering to the iris with contraction. If it is insignificant, again you observe. Significant, you have a healthy endothelium, you do the same management. And in tractional, you have a very taut membrane, so doing a relaxing desmetotomy helps you. So you do a relaxing desmetotomy, inject air, give the patient position, and your DM is going to attach. And if you think that this is an endothelium which is not going to recover, then you have to do an endothelial keratoplasty. And if you have a complex detachment, then I think, for example, if you see your lenticule is not attached. I'll show you an OCT picture where the lenticule is not attached. You have to do a reflotation air injection, and that will attach your DM eventually. So this is one case where an air injection was done. You can see this is a typical regmatogenous DM detachment. An air injection was done. Patient was given position, and the desmets attached eventually. So for certain cases where you think that air injection is not going to work, you can use expansible gases like C3F8, SF6. And this is a post-Desect surgery. An ultra-thin Desect was done for this patient. You can see that there's a detached graft, and reflotation was done with air injection. And 1 month post-op, you can see that the desmets is attached very well. So it's a short presentation. I would like to conclude here by saying that a good surgeon is not one who does a good surgery, but a good surgeon is one who also does a good surgery and recognizes the complications on table and knows how to manage them. I think in desmets detachment, it is very important for you to know whether you actually have a detachment or something else, and if you do, what is your type of detachment and how are you going to go about managing it. Thank you.
Thank you. Thank you, Priya. That was really wonderful. Meanwhile, Prashant is setting up his presentation. I have one question for you.
Yes, sir.
So, how late you can do a desmetopexy? If you get a patient who has come after like probably a month or so, latest how long you can go ahead and try out pneumodesmetopexy or desmetopexy in any form?
I think, sir, if you ask me how early, then I would definitely want to wait for the inflammation to subside. But if you ask me how late, then whenever I see the patient, I would definitely give it a try of doing a relaxing.
If patient comes after 1 month, you still can try?
Yes, at least up to 6 weeks, I would safely go ahead and try doing it. And I think probably the worst thing that would happen is it would not reattach. So I wouldn't mind giving it a try, sir.
Yeah, sure. Vikas, I have one question for you. She showed one of the type was DM lost during cataract surgery, and it's not uncommon that sometimes the surgeon ends up doing a desmetorexis and desmet is lost. Now, intraoperatively, God forbid it happens in your hand, and you have tissue availability in your place. Would you go ahead and do DMEC on the same setting?
Short answer is yes, for sure. In case I am sure that is a DM which is detached. So I think a month back, a friend of mine, he called me up. He said that because I've lost a DM, he's a general ophthalmologist, and I think it will need a DMEC or Desect. I said, are you sure? He said, yes, I'm very sure it was DM which came out. And I said, okay, fine, we'll see. So next day he said that there's a total corneal edema, but guess what? After 3 weeks, it resolved. So what he thought that it was DM which had come out was actually a capsule. So we have to be very sure that this is DM which has detached. But if it's DM, you are sure, you can definitely think. One thing I would like to add to that is, I think we must not use viscoelastic to reattach the DM. Sometimes, if you have a DM detachment during the phaco, you're doing a phaco and you can see the DM has detached. So I remember somebody discussing long back, and he said that I had injected viscoelastic and continued the surgery. This is very dangerous because if the viscoelastic goes in the interface, this will never get attached. So the very important thing is that we must, not use viscoelastic. And I remember one more instance where somebody said that because this patient needs a Desect. And surgery done around 3 months back. He said it is not resolving. And when I saw, there were DM tags here and there. So we said, okay, and the patient was ready. He said, no, go ahead and do a desmetopexy or Desect. So, but we just did a desmetopexy and resolved. So even after 3 months, I'm sure that we must have seen patients even after 6 months, 8 months. You can give it a try before, going ahead with the endothelial keratoplasty.
There are also, because some anecdotal reports of patients who have definitely lost decimase, and after 2 or 3 months their corneas are crystal clear. So how would you explain this?
God is around. So it's very difficult. So maybe there is something about the cornea that we don't know yet. So if we are sure that DM has come out, so maybe there are some backup stem cells somewhere which yet to be seen.
No, you can have, like I've seen patients where the central, maybe even 5 or 6 millimeters is lost, like Nowadays, there is this terminology of DWEK or whatever it is. But, and then the patient has recovered. If the peripheral cell count is pretty good or the endothelium to begin with was overall healthy, then the peripheral endothelium can slide over. And I think ASOCT can also help us to show where the DM is there or not there or it's missing. Because it can help us to know what is happening. So I normally would wait even if there is a central DM loss. Many patients will recover, but if you have a patient, let's say, who has Fuchs like picture or Gateta, very severe, other eye endothelium is extremely bad, and then you have a central DM loss, then the possibility of recovery may be low. But healthy corneas, other eye looks very healthy, they may recover. So it's happened to me that I told, okay, you register for surgery, and then because we don't get corneas, when the cornea came, cornea is already clear. So I think sometimes patients will help.
Priya, one question for you. So when you do a pneumodesmatopexy, how do you prevent a glaucoma post-operatively? What care you take, and what do you suggest other general ophthalmologists to be careful about?
So I think anti-glaucoma medications are a must when you're doing when you're doing relaxing. So you have to give anti-glaucoma medications in your post-op regime. And I guess nothing.
And the size of the gas bubble, how much do you keep the size of the gas bubble? Do you do the full chamber fill? Or
no, usually not. 3/4, not more than 3/4.
Yeah, so basically 3/4 chamber fill, intraocular pressure on table should be good enough. And as she said, keep patient on anti-glaucoma medication, and just be aware that there can be still chances of pupillary block, and patient might actually call you up in the night with headache and vomiting and those things. But well, at least it will make sure that DM is attached. Along with that, maybe iris, but DM will be attached.
Sir, am I allowed to ask a question?
Yes, please.
So there was one of my friends who had referred a patient, and he gave me a call saying that there's a Desmond detachment, and I want you to see what you can do about it. So he said, okay. And then the patient didn't come for about 15 days, and then he said that the patient has come, and the patient seems okay. It seems like the patient is not complaining anymore. So then we eventually saw the patient, and I didn't see the decimates detached from everywhere. So probably it was a spontaneous reattachment. So how do you explain to this? I mean, if your general ophthalmologist friend refers this patient to you, would you tell them that we can wait for a spontaneous reattachment, or would you intervene, or what do you do if this kind of a situation arises?
So that's very good question, that not every DM detachment requires surgical treatment. The shallow detachments, what we call non-planar detachments, and we can wait for them, especially in the periphery. But having said that, earlier time, our experience of air and those things were not so great. And now with DMEC, Desect coming, injecting air in anterior chamber is sort of not that alien to us. So my threshold for treatment would be very low compared to earlier it would have been, where I would have waited longer. Now possibly the injection becomes a little more earlier than later.
Okay.
Thank you. Thanks.
Yeah, thank you, sir.
We'll move on, and next speaker.
So can I? Yes, please.
Yeah. So, sir, while doing the surgery, many times, while injecting the ILA or sometime, the Desmond get tear, and generally it happens in somewhere in the central or pericentral area, and the Desmond get folded over it. So even after putting the air, it may not actually get reattached, and it get actually folded. So is it a good option that we actually fold it, push it back with the iris, spatula or some repositor, because ultimately we are going to touch the endothelium. So how it should be dealt with? Because if it is in center, then ultimately post-operatively there can be, even if the cornea is eventually would be fine, but then astigmatism going to be a real issue. So what we can do, like, is it right thing to reattach with the iris repositor or some instrument? Because
Yes.
we are dealing with the endothelium
True,
again.
true. So you are talking about the non-planar detachment, I think, which is a larger flap which has got folded, right?
Not the larger, but even smaller one. But if it is in the center, then that's really going to create issue in the long term.
See, now as we keep on doing this DMEC and Desect, so in those also, in case you have a fold, you can try to tap it on the surface, and in case it doesn't go, you can keep a air bubble low, and then use a reverse Sinski, and you can actually nudge it. But even with a surface tap, it comes. But if it's a larger one and keeping it folded is not a good idea. We should try, once you remove the air, put fluid again, it tends to uncurl. So it is very difficult, the flap will not remain folded. If with the fluid, it will definitely uncurl, and then you start injecting the air bubble where it is attached, and come, say, if it is attached at 3 o'clock, and coming in the center, so go in the periphery at 3 o'clock from 9 o'clock, and then you start injecting the air, and then it generally, unfolded. But keeping it folded is not a good idea.
Yeah, that is
Also nowadays with the DMAC and all those things, we have touched endothelium so much. As a cornea surgeon, a controlled touch is not as bad as sometime unaware, uncontrolled touch as a general ophthalmologist you end up doing. But I think endothelium is quite forgiving. But as Vikas said, I think we should be a little careful there.
All right, thank you.
So may I now invite Dr. Prashant Bhartiya, and he will be talking to us on how to start treatment in case of a microbial keratitis patient. Over to you, Dr. Bhartiya.
I think I am audible now.
Dr. Bhartiya is a cornea specialist from Indore, and I'm sure we'll get a very good insight. And as a general ophthalmologist, this is a very important topic because we keep seeing corneal infections day in and day out. Over to you, Dr. Prashant.
Thank you. Good afternoon, everybody. Now, how to start treatment in a case of microbial keratitis? Not a very simple question to answer, very detailed. I will go from what I do when I get the patient for the first time, first consultation. What I do is I try to arrive at a clinical diagnosis, then initiate appropriate testing, probably start with empirical or some initial therapy, and also give the supportive treatment. In any case of keratitis, there are 3 management components. I will include all these in starting the treatment because all these are interrelated. It's actually a cycle which goes on and on. So you make a diagnosis, you start treatment, you see the response to treatment, and then again reassess your diagnosis. So I'll just deal with one cycle because we are going to deal with the starting of the treatment. So when you when we plan about diagnosing what the patient has, you have to systematically document whatever you are seeing, whatever you are hearing from the patient. So you should document each and every aspect of his history. You should also note what previous treatment he has had. You should note the various details of the ulcer and other features which are there. You should keep a high index of suspicion from the from the start of the systematic documentation. Like in the history, if you have an acute sudden episode, it might be an bacterial keratitis. If it's been a little longer, probably more than 7 days, it could be fungal, as you can see on these pictures. You should, when you are seeing, you should document the lids. The lids can give away a lot of things. Like in the top image, you can see that the patient has a scar from blepharitis, and he has a marginal keratitis, which looks like infective, but actually would respond to steroids. In the photo on the bottom, you can see that the patient has exposure keratitis, and the ulcer is quite corresponding to the exposure. You should document the size and obviously the shape of the keratitis, of the ulcer, which can give you a significant clue. Like it could be dendritic, it could be a whorl-like pattern in a wreath-like pattern in nocardia, or it could be a geographic ulcer. You should note the other features, like there would be vascularization, there could be a leak, there could be an hypopion, which I have not shown in the image. You should document the size of the hypopion. Should also note the systemic issues, like the patient could have allergies, the patient could have a rheumatoid features on his in the fingers. Now, as part of the microbiology, I think the crucial step is the microbiology. Now, you would say that why should a general ophthalmologist worry about microbiology or scraping? But I would still emphasize that scraping is the cornerstone for treatment of keratitis. The bare minimum would be a KOH mount. This should give you the maximum information for you to start treatment. If you can go ahead and do the gram stain, probably take cultures, the bacterial culture plates, the fungal culture plates, these are available from your microbiology labs, and you can probably do the full set of scraping, but the bare minimum would be at least the KOH mount. You can have special tests also, but in the initial, this is beyond the scope of my talk. So nearly all cases would need scraping. In which cases you may defer this scraping, maybe if the patient has been responding to the treatment which the patient has got when he has come to you from the consultant before, or if it's a definite clinically proven, clinically definite herpes simplex keratitis, or if you feel it's a deeper one and the surface and antiostrom are intact and you would like to start the treatment and then probably see the response. In a case of perforation, should we do scraping? As a cornea specialist, I would say yes, because you might end up doing some surgical procedure, and if you have a etiological diagnosis, it will actually be easier post-surgery. So you can carefully do it from the edges. Once you have come to some clinical diagnosis, you will initiate your medical management, and I have borrowed so heavily from this article from Dr. Nikhil Gokhale that I needed to show this. You start with empirical treatment according to the clinical diagnosis. I'll come to this part. You'll give symptomatic treatment. The risk-benefit analysis for giving steroids say that it's a big no. You shouldn't start with any sort of steroids. This is a very clear-cut message to the general ophthalmologist, which I would like to give. You should also, importantly, look into the local risks like the entropion or the exposure, and probably systemic issues like if the patient has got rheumatoid arthritis or is on steroids for, say, some eczema or others. And you should also assess the response to treatment which was given before the patient reached you. Empirically, you could start with either fortified drops or with fluoroquinolones. This table from Dr. Gokhale sir's article very nicely describes my preference is fluoroquinolones because they are cheaper, they are more stable, they are available in a bottle, you don't have to make them, they're less toxic, and they have got more shelf life. Otherwise, the others have to be disposed of in a week. For the fluoroquinolones, you've got multiple options: ciprofloxacin, gatifloxacin, moxi, and now becifloxacin. I feel gatifloxacin and moxifloxacin are very good. I have no experience with becifloxacin at the moment, and for a general ophthalmologist, I would recommend either gatifloxacin or moxifloxacin, as you can see from the table. How do you start this treatment? So you give a loading dose. The loading dose would be, you would start with the medication every 5 minutes for the first 30 minutes, and then every 15 minutes for 1 hour and 1.5 hours. So that is 12 doses in the first 2 hours. And then you will shift to hourly doses, and that too round the clock. You will have to advise the attendants to help out, because the patient will have to be given drops round the clock when you start the medication. Other routes like subconjunctival injections, they have no role. Systemic antibiotics you can give in case of perforation, or if there is scleral involvement, if the patient has endophthalmitis and has come with you with a corneal ulcer, or if there is a proven gonococcal infection. Supportive treatment is very important for you to gain confidence with the patient. Because if the patient doesn't get pain relief, he's not going to, even if his ulcer is getting better, he is not going to feel better. So pain relief can be with oral or many times with injectable NSAIDs. IOP control is important. Cycloplegia is best done with atropine. You can try hemometropine also. I'll just delve into a little part of the initial or the specific treatment if you have got some microbiological evidence. Like if it is a patient of Pseudomonas, or if you are strongly suspecting Pseudomonas keratitis, you could start with a combination of moxifloxacin or gatifloxacin along with amikacin, and then shift to specific drugs according to the sensitivity. Most commonly which we get is ceftazidime, imipenem, and sometimes colistin. Fungal keratitis, natamycin is the drug of choice. You don't start with voriconazole or amphotericin B. You start with natamycin. That is the standard preferred treatment. you go on with 1 hourly, and you may have to add voriconazole, amphotericin B, itraconazole later. You might get cases with nocardia. I had shown a photo with a typical wreath-like pattern, and sometimes in the immediate first KOH, you can recognize nocardia elements, and you can start with amikacin. You might have to shift to specific drugs like Septran or ciprofloxacin or imipenem, but most of them are sensitive to amikacin. Herpes simplex keratitis, usually very typical epithelial disease, responds well to acyclovir eye ointment. You don't give steroids if it is purely epithelial disease, and you don't give oral acyclovir unless the stroma is involved. In stromal or endothelial disease, you give oral acyclovir, and you may add topical steroids once the epithelium has healed. So the takeaway message here is you add steroids only once the epithelium has healed. So response to treatment assessment is an important part of your management. Whatever the treatment has been given before, you need to assess whether the patient actually got better or not from the history. From your treatment, if you need to assess whether patient is getting better or not, you will have to quantitate and document each and every symptom and sign, and then define the response, whether it is better, same as before, or worsening, and then probably change course. If you get a non-healing or atypical keratitis in the first go, I think an early referral to a cornea specialist is warranted. Don't start empirical treatment for a presumed acanthamoeba keratitis. Don't do empirical treatment like that unless you have got good microbiology, and microbiology is a must in such cases. You should document whatever treatments you have given, whatever previous treatments have been given, and then you should forward the patient. So you should avoid confusion, keep a systematic approach, document each and every aspect of the clinical signs and symptoms, make a proper clinical diagnosis, go ahead with the treatment, and then assess the response, and then go ahead from there. Avoid confusion. Thank you.
Thank you so much, Dr. Bharti. I think this is such an exhaustive topic, and you have covered comprehensively so well. So since we see a lot of fungal keratitis, and it's maybe more than the bacterial that we see, where do you start systemic antifungal agents? So do you have any subset of patient where you would prefer to add a systemic antifungals as well?
Yes. If the epithelial defect is larger than 50% of the cornea, probably, and especially if the limbus is involved, it would probably warrant a systemic antifungal. If there is a significant hypopion, significant means more than a millimeter or so, that means there is something which has gone into the anterior chamber. If the patient has got systemic comorbidities, especially like diabetes, or if the patient is on steroids oral for whatever reason, maybe systemic like eczema, allergy, rheumatoid, then I would probably add oral antifungals.
Great. Dr. Nikhil, when do you want to start voriconazole in a patient of fungal keratitis, specifically a different mode of delivery like intracameral injections, or when do you want to give only one drug, natamycin, or where you want to do combination? How do you decide that?
So if we assume that we are not doing or we don't have the culture of what exact fungus has grown, but we know it's fungal keratitis, normally I start with single drug therapy. That would be maybe natamycin as the first drug. If we have a situation where we see that the patient has come to you already using one drug, or the patient has a, as he said, extremely large exudation in the anterior chamber or very severe form of keratitis, you could start 2 drugs at a time. So you could start, say, natamycin and voriconazole, or if you find that after giving one drug the ulcer is not responding at all to treatment or getting worse with time, before you consider some intervention, I think it's worth trying adding voriconazole. And then, of course, we have to look at what may be the indications where you want to give intracameral wash and remove all the exudates. Sometimes it helps for diagnostic microbiology as well as therapeutic responses there once you give it inside the eye, and also you can give intrastromal. However, I think as a general rule, we need to remember that whatever we do intrastromal or intracameral, they have limited effect. So it's not going to, one injection or one intracameral may not be adequate for severe cases, and it may give you transiently some improvement, and then you might have to repeat it. So we have to be mentally prepared that it's not sometimes just one injection which may be adequate, and be prepared that you may have to give more. Otherwise, the patient may again worsen, and finally you may need a therapeutic graft.
One question for you. Many times we see when we get a referral patient, they are on polymicrobials, like 3-4 antibiotics, antifungal, antivirals, and all those things. So for a general ophthalmologist, how do you start with, if, as you said, that we must scrape, and if they are not scrape, based on clinical suspicion, is it right to start antifungals, or how do you suggest, what do they start with?
I think if you're not doing scrapings and you want to start treatment, ideally it would be best to start an antibiotic initially, at least see what is the response, unless you're very sure that this looks fungal and you have that experience to say that this looks like a fungal ulcer, maybe you could consider. Otherwise, when we give combination treatment, it adds to the toxicity and creates confusion. So I see in my practice, for example, patients referred saying that 2 drugs have been started or 4 drugs are started, patient seems to be getting better. At that point of time, I have nothing to offer them because I have no report. I don't know which drug is working. So it's a very difficult situation once we start multiple drugs. So I would suggest we start one drug, see the response, and then if not improving, consider doing a scraping or send the patient to a center where scraping can be done. And also remember that there are some situations where we should not treat a patient empirically at all. For example, let's say you have a child with a corneal ulcer, or you have a post-surgical infection, you have a severe ulcer. So I have some indications where if the ophthalmologist does not have scraping facility, he should just refer the patient straight away on day 1 rather than doing trial and error. So when we have situations where you may lose the eye very quickly, best not to do trial and error. But if you have a more indolent ulcer, maybe you have room for doing some experimentation. But otherwise, we need to see what is the speed at which the ulcer is progressing, and then decide whether you want to keep him with you or send him higher up.
Prashant, one question for you. If a patient, you do scraping and it does not reveal any organism and it comes negative, would you repeat the scraping, and how often, and like what's your cutoff? Do you repeat scraping as many times as you want till you are convinced about the report?
At the onset, you would do scraping. You would start your treatment as sir said, with empirical antibiotics rather than antifungals, because if you say that there is no organism. And you would wait for at least 48 to 72 hours to see if there is any response. If there is no response in 72 hours, by the time you would get some culture report. If there is nothing on the culture, then you can decide whether you need to re-scrape or probably do something. But I think the re-scrape is the best possible option if you don't have a response.
Sure. I think it's very important for the general ophthalmologist to remember that it's not one-time test. If you think that there is no threatened perforation by scraping, scraping it again is certainly nothing wrong there, and you must try it out till you're convinced about the outcome which you have in terms of the result of the test. Dr. Nikhil, one last question to you. Replacing the antimicrobial versus adding the antimicrobial, how do you decide when it's not responding to treatment?
Yeah, I think it's, we need to judge. For example, let's say we are talking of an bacterial or fungal or what, it might be different answer for them. But in general, if we feel a drug is not working, I would rather replace it rather than add more drugs. Because as I said, if the first drug was not working in the first place, then possibly you put a new drug and withdraw or stop the first drug. The other situation is when the first drug seems to be not really helping, but it's not worsening as well. So the picture is more or less stable with the drug on. So you feel some effect is there, you could consider reducing the frequency and then adding a second drug which probably might be more effective. So these are very day-to-day decisions. If you don't have any report, you have to take based on your clinical sense. But in general, multi-drug therapy or giving multiple drops, like for example, I've had patients where a fluoroquinolone was started, patient is not responding, the doctor added 2 fortified drops, and now he's on 3 drugs, putting every half hour or 1 hour. So I think that probably has a very limited role in our practice. We should restrict, rather if you start 45 drops, stop the fluoroquinolone, because there is no point of giving multiple drugs which may have no additional effect but rather deleterious effect.
Thank you, Prashant.
Thank you.
It was
Yes,
really,
there's a
okay, I think, yeah, please go ahead. Yeah. Prashant, can you be around? There's one question. Yeah.
Good evening, sir. So I wanted to ask.
Can you speak in mic? I think you're too tall for a mic. Sorry, turn it up. Yeah, please. Yeah, that's working. I think I can hear that.
Hello.
Yeah.
So in a patient where you know that it's fungal keratitis with a hypopion of, let's say, 4 mm, 5 mm with deep exudates or endo-exudates. So, and you don't have a culture-proven organism yet, but you want to give an intracameral injection of voriconazole or ampho. So what injection would you prefer, amphotericin B or a voriconazole, if first time you want to give? And a small question to that many people are afraid that if we, even from the clear side, if we inject intracameral, we are creating a tract, and by washing the AC, we are getting the exudate out and patient may go into endo or something like that. So how do you tackle that?
No, see, only one thing you need to look whether the cornea is tectonically stable or not. So if you have a patient where the cornea is strong enough, but there's everything inside the eye, as you mentioned, what I normally do is to make 2 side ports, small side ports, and do bimanually, wash out entire stuff and put intracameral. Presently, I prefer voriconazole. In the olden times, I used to use more of amphotericin when we did not have voriconazole. The other situation is if your cornea is tectonically weak. For example, there's a large ulcer which might perforate, which is very thin, where there is a lot of stromal melting. So in this situation, washing the chamber may not give that benefit, because you finally may end up doing a therapeutic PK. So as I said, you might have to repeat the AC wash, or you might have to sort of give the intracameral again. So you need to see how is the tectonic configuration as well, because if that is good enough, then you can get along by maybe 1 or 2 injections and drops and stromal, and all those things can be done.
Sir, but voriconazole is what you would prefer first?
Presently at least, yeah.
Okay, sir. Thank you, sir.
Thank you, Prashant. So we move on. Next speaker is Dr. Ahmedita Ajani. She is an associate professor of cornea refractive surgery and cataract surgery in Cooper Hospital, Mumbai. Amrita is going to talk to us about management of acute chemical injury. Over to you, Amrita.
A very good afternoon to all. I'll be speaking on managing acute phase of chemical injury, and this is the scheme of my talk. Chemical injury is a true ophthalmic emergency, and we should keep in mind that besides the ophthalmic presentation, the patient could also have any bodily injuries or any respiratory symptoms or any laryngeal edema, and that also needs to be taken care of. As far as the ophthalmic treatment is concerned, the first and foremost is immediate eye wash, for which the ideal solution is diphoterine, which is amphoteric, meaning it can neutralize both acid and alkali, and it's not exothermic, that it does not release any heat. But in our daily clinics, we may not have this solution, so it's always preferable to use whatever we have, which is usually BSS, RL or NS. And sometimes in the factory place where nothing is available, even tap water is okay, though tap water being hypotonic can increase the corneal edema for temporarily. Another important point is removal of the impregnated particulate matter, which is sometimes deposited over the ocular surface. So the manner in which you need to irrigate is the patient lies down, you can give a topical anesthetic for patient comfort, put in a speculum, have a slight head tilt with a kidney tray to hold the draining fluid, use a simple IV set, and you can irrigate from the medial canthus towards the lateral canthus, no fancy equipment required. And you need to check all the pharynces thoroughly for any particulate matter. So a Desmond's retractor may come in handy for eversion and double eversion. So the question is how much and how long? Generally, the endpoint is a litmus paper test, which helps you test the pH. But in case if that is not available, so roughly you can irrigate with up to 3 liters of fluid, and up to 15 to 30 minutes of irrigation time is generally required. However, I need to emphasize again that the timing of intervention is much more important than the choice of the aqueous solution. So while irrigating, you can take a history if the patient is comfortable. This is one of those few emergencies where the history and examination is done later on, and emergency management is given first. So in the history, what you really need to ask is whether it was an acid or an alkali, if you could get that history, because alkalis are lipophilic and they tend to penetrate deeper into the tissues. Also, you need to evaluate the patient and classify, and for that you need some fluorescein to evaluate how much of the limbus is involved. In the case of children, they need to undergo an examination and anesthesia to thoroughly check the ocular surface and also to check the phonesis. These are usually workplace injuries, so documentation is a very important part because they may just be a medico-legal case. Currently, the present classification is Dua's classification given by Professor Harminder Dua in his BGO article, and that gives a better prognostic predictive value as compared to the earlier used Roper-Hall classification. He has described the classification into 6 grades, and this is based on the limbus involvement and the conjunctival involvement in terms of percentage or in clock hours. And what you need to keep in mind is that you have to regularly follow up these chemical injury patients. And as per the Dua's classification, the classification is going to change daily if the epithelialization is progressing well. So these are a few cases of chemical injury. The top left corner shows you the grade 1 injury where no limbus involvement is there. The top right shows total limbus involvement, so that would be grade 6. Besides the limbal involvement, there are certain factors like scleral ischemia or any impregnated matter, particulate matter or phoneal matters that needs to be looked into besides the Dua's classification and needs to be documented as well. So the aims in the acute phase, which is generally less than 4 to 6 weeks from the injury, first and foremost is the epithelial healing, second is the control of inflammation, and third is the control of intraocular pressure. So for epithelialization, the milder cases do well with preservative-free lubricants. In case of the severe ones or the non-healing ones, you would want to go in for the biologicals like autologous serum or umbilical cord serum or platelet-rich plasma. Vitamin C is an essential cofactor in collagen synthesis, and in a chemical injury, the ascorbate or levels of aqueous goes down, hence you need to supplement it. Topical is a little difficult to dispense, so generally oral is given in the dose of 500 mg QID. Another important adjuvant is tetracyclines. Usually we give doxycycline. This is an anticollagenolytic, that is, it inhibits the matrix metalloproteinases and hence it reduces corneal melts. The mainstay of anti-inflammatory treatment medically is steroids. Usually the potent steroids are used. We all know the mechanism of action of steroids, but what is important here is that at the end of 7 to 10 days, if the epithelium is not healed, then the frequency of the steroids need to be reduced because otherwise then it can lead to melts. Certain adjuvants like cycloplegics for pain control, antibiotics to prevent infection, and AGMs to control the IOP are also required. A BCL may also come in handy for the epithelialization, and it also prevents the new growing epithelium from the friction of the eyelids. The acute phase also has some surgical management in case of the severe injuries, including the debridement, tenonoplasty, alloslet, TABCL in case of perforation and amniotic membrane grafting. Amniotic membrane grafting has a multi-fold effect. It may be glue-assisted or sutured amniotic membrane in any form. It helps to reduce inflammation and also provides a scaffold for epithelium healing. However, there have been certain RCTs which have shown that in the long term, they may not be an added advantage of using an AMT over the medical management. Nonetheless, AMT has been very handy in terms of chemical injuries which are not doing very well. The intraocular pressure may rise or may fall due to different factors. Sometimes there is a balance of these factors which causes the IOP to remain the same. Nonetheless, keeping a check over the IOP on subsequent follow-ups is very essential. And if treatment is required, usually oral acetazolamide is a choice, because anyway you are using a lot of drops, and the drops are mainly, the topicals are usually acting on the trabecular meshwork, which sometimes is damaged or blocked because of the chemical injury per se. Tenenoplasty is a modality that is used for severe cases wherein tenens is advanced from mobilized and advanced towards the limbus, and it is sutured there, but it's useful more in the severe cases to prevent anterior segment necrosis. If tenenoplasty is not possible, there's also an option of free conjunctival autografts in unilateral cases where the vascularized areas are sutured to the distal border of the ischemic area. In 2020, the SN group proposed a new modality of treatment for acute injuries, and that was allo-SLET. Here, the source of the SLET limbal stem cells was cadaveric, and this enabled them to give an external source of cells to repopulate the AMG. And the aim here is not long-term survival of the graft. The aim here was rapid epithelialization, so that the chance of melt is lesser. So overall, besides that, the rapid epithelialization also leads to faster inflammation subsidence and decreased incidence of symblepharon and corneal scarring, and the need for any keratoplasty. So this is just a protocol given by Dr. Professor Harminder Dua in one of his articles, where everything is listed down very well. So we could just, the general ophthalmologist could just put up such a protocol so that no point in the acute management is left out, because the acute management has a very large bearing on the chronic sequelae and complications in a chemical injury. So the take-home point is a thorough eye wash is an absolute must. A long-term follow-up is definitely necessary to look out for sequelae. Glaucoma is an important cause of vision loss and is often overlooked. These are my references. Thank you very much.
Thanks so much, Amrita. I think that was very nicely covered. And from general ophthalmologist point of view, I think it's very important to know that epithelialization is very important, and anywhere where there is ischemia, that has to be covered with tenenoplasty. So my question is, do you like to do a tarsorrhaphy also in acute phases? Or if so, how do you titrate that this will help?
We can assess the healing, because if you follow the rules of corneal healing, that it heals in convex manners from the limbus towards the center in a manner that it is supposed to proceed. And if the patient is healing well, then medical treatment is enough. But if it doesn't proceed the way that is planned, then probably yes, we can even consider that.
Okay. Dr. Nikhil, so suppose you have a chemical injury where you have significant ischemia, you are doing some tenenoplasty or anything. So do you like to do a tarsorrhaphy in first go also? And second, if she has rightly pointed out that you need to give steroids. So what is that phase where you feel that steroids should be given and when it should be actually stopped?
Yeah, so I think if you have significant ischemia, probably the AMG can be combined with the tenenoplasty, so that you bring in circulation into the ischemic area and promote healing. Surgery, whenever it is required, most of these patients have relatively moderate to severe burns, so I would always probably do a tarsorrhaphy in these patients. There is absolutely no harm. If at all, it will help to promote healing and also help to retain the AMG and your whatever procedure you have done. And then steroids, of course, we need to start in all chemical injuries from day one, unless there is some evidence of infection or something like that. But otherwise, because very often, at least in the past, I used to have doctor calling that there is a total defect. So, we have always been taught that if there is epithelial defect, total staining, people were afraid of steroid, but I think the anti-inflammatory effect is required, and we need to start them right away. And then, as she said, monitor the surface healing and then titrate how much of steroid needs to be continued, or if there is any stromal thinning, these things we need to watch for.
One more thing which I would like to point out here is many times in most of these classification where we make things too generalized. However, each chemical injury patient is different. So evaluating each patient gives you an idea how this patient might heal. And that's where we learn the healing pattern, different healing pattern. So I personally, I'm not a great fan of ischemia grading and all such kind of thing. I would rather look at the limbal epithelial defect. The form of limbal epithelial defect allows me to know that how much time it's going to take to heal the surface. Let's remember that ocular surface melting, or rather corneal surface melting, occurs when there is an epithelial stromal interaction. Whenever epithelial defect heals, the melting of stroma is unlikely. Now, whether it heals or whether you artificially stop the entry of all your chemokines and inflammatory mediators and cells into stroma, that's still similar. So, if you put an amniotic membrane, well, the chances of melting is again going to be very less. So, if you have a case with a large amount of epithelial defect, but it has not crossed limbus, the likelihood are that that epithelium will heal much faster. But same time, if you have a limbal epithelial defect which involves more than couple of clock hours or more than couple of quadrants, for that to heal is going to take significantly longer amount of time, and by then the cornea can have melting. So doing amniotic membrane transplant would be very important. So I personally feel drawing a diagram of your staining pattern would be very important, and it will help the next surgeon also. When you refer it to a cornea surgeon, it will certainly help a cornea surgeon that how the staining pattern is.
So in fact, we had looked up our cases of pediatric chemical burns where we had a grade 4, grade 5 burns where there was a limbal epithelial defect along with ischemia. It took 3 months, 2 to 3 months for whole epithelium to come back. We kept on doing AMGs and tenenoplasty and tarsal Herpes. So you are rightly said that if you have to wait for epithelium, the moment epithelium comes, inflammation goes down. Thank you so much, Amrita, for a wonderful talk. Thanks so much. So maybe invite our next speaker, the dynamic Karan, Dr. Karan Bhatia from Meerut. He has recently started his venture called Drishti Eye Foundation Meerut, and he is going to talk on corneal perforation, and he's a very interesting presentation. I'm sure we are all going to enjoy. Over to you, Karan.
Thank you, CSI, for the opportunity. So how to treat a corneal perforation is always an enigma for a lot of general ophthalmologists. So that's why this presentation is tailored specifically to them. So a corneal perforation is an emergency. It can have a variable presentation. Multiple causes have been described in literature. They can be infectious or non-infectious. The non-infectious could be ocular surface related or autoimmune or due to a trauma itself. A history and a good corneal workup is extremely important. This is what we were following for every corneal ulcer when I was working at Sitapur Eye Hospital. So in history, what you need to stress on is there a sudden drop in vision? Is there any pain? Any history of trauma, surgery, contact lens use, any herpetic eye disease, and the use of any medication. Most of the times they are using a topical steroid. Also stress on systemic issues like diabetes, any systemic other issues as well. What you need to see is instruct the patient not to squeeze the lid. Look for iris prolapse because it's often there, as you can see in the picture. Do a Siedel's test if you're not sure, and if sometimes you need to do a forced Siedel test or a pressure Siedel's test. And if possible, if there's not a much of a perforation, you can do a Roplas as it is indicated in all corneal ulcers. A lab diagnosis, already the previous speaker has spoken upon it. So gentle scraping can be done. You can do that. If it's a perforation, you can actually do the scraping in the OT also. And if you can do a grams and a QH, it really helps. For any contact lens user, the contact lens case and the cleaning solutions have to be sent, and always do get a blood sugar tested. So due to COVID, there was a pandemic, and the issue, there were a lot of papers came out, and in the first wave itself in United States, elective corneal transplantation came to a halt, and there was a lot of scarcity of the corneal tissue. So it was time to get smart and basically come up with management guidelines that was specific to these times and to deal with the scarcity of this corneal tissue. So we came up with these guidelines and we followed it in the COVID period. But these guidelines as well, the same guidelines can be applicable for a general ophthalmologist, because you are not going to do a keratoplasty. So, but the added thing over here would be to refer to a cornea specialist whenever in doubt. And once you've done the primary procedure, you can again refer it if the patient is too far away. So for any impending perforation, I would recommend to do a tissue adhesive and a bandage contact lens. A tissue adhesive meaning a cyanoacrylate glue or a multi-layered AMG as well. For 1 to 2 mm perforations, you can do a tissue adhesive and a BCL. For more than 2 mm perforations, you can do a TA-BCL, or you can use a surgical drape along with the TA-BCL. I'll show videos of this. Or you can do a Tenen's patch graft or a conjunctival pedicle flap. For large perforations, what gentle situations could be, if it's normal, you can do a gentle B-scan very, very carefully. You have to be very careful because actually it's not indicated to do a B-scan in any perforated eye. You can do a modified Gunderson's flap, or sometimes you can just do a temporary tarsography or patch the eye and send to the cornea specialist. This is for the COVID time, so you can refer it. So let's look at a couple of examples. So most of these videos are during the COVID time only. So so what you need to do is dry the surface first, and once that surface is dry, you can apply small drops of the cyanoacrylate glue, wait for it to dry, and just put the BCL. Now this is another example. So what we did was, there's a slightly larger perforation. So we tried to dry them off, and this is this eyelash drape that you get with your surgical drapes. So it was kept slightly around 40% larger than the size of the perforation. A glue was put, and immediately on top of it, without it letting to dry, this surgical drape was put. Then again, glue was put, and immediately again, without letting it dry, a BCL was put. So it's giving a 4-layer of protection over here: a layer of glue, a layer of drape, a layer of glue again, and then a layer of BCL. Let's look at another case. So this is a post-perforated ulcer. The cyanoacrylate glue was applied, as you can see in the video. And immediately post this, the surgical drape, which was fashioned, was put. So you have to remember, these are temporary procedures basically to help save the eye. And then once it dried nicely, I could go inside the anterior chamber and basically inject air as well to form it and release any adhesions that are there. Since it was not forming, I could make a side port. The air was not forming completely, so I made a side port, put in a little bit of OVD, and then release this Sinica as well. So you can see how stable this is. So it's almost like, a new cornea, an opaque cornea that has been put there. And then at the end of it, after washing the OVD, a full air bubble was put. The antibiotic was put inside the eye as well, and a bandage. After putting a drop of glue again, the BCL was applied. So this patient, you can see as of 23rd July, this was the procedure that I had shown the video, and of September, this is this. Yes, there is vascularization, but we have managed to save the eye. This is another example. This is a very old video. So you can see about 2 mm perforation or something, or maybe a little bit more than that, 2 to 3 millimeters. And so this is the cardboard part of the drape that we have used as a temporary procedure, and then we would do a keratoplasty later by a cornea surgeon. So this was put, it tucked it inside the corneal stroma, and then again a drop of glue was put. And to actually help it polymerize a little bit more, you can put a little bit of saline and it polymerizes more. And then air bubble was put inside the anterior chamber and formed. Then again, a little bit of drop of glue, and then the BCL was applied. So if it's a peripheral perforation like this, you can do a modified conjunctival Tenen's pedicle flap. What you need to understand is that the Tenen's is important in such situations because it is the tough structure. The conjunctiva is a very friable and a very thin structure. So you need to advance this about 1 to 2 millimeters, a little bit more. Ideally, it should be whatever, it should extend around 40% more than the size of the other side. And this is one of the cases, did pretty well. Tenon's patch graft, I don't have a video of that. So what you can do is, again, as I would say, 40% more than the size of the lesion. And recently there was a case of post-bullet injury. Pellets were there in both the eyes of this young lady, where there was a perforation as well. So I had fashioned a Tenon's patch graft, and then you can suture. It really does well with that. So this is another for large melts. So what this is that time again cornea was not there, and so this was a modified Gunderson's flap. So again in here what you would do is you need the tenons. 360 degree around 14 millimeters, 12 to 14 millimeters behind the limbus. You would make a cut up to the about 0 and 180 degrees. And once that is done, you can reflect it over here and then suture. Remember, the suture should not be in the center because this flap is going to retract. And this can be done easily by a general ophthalmologist. And the suturing should be tangential to the limbus, and it should cover it like this. See this flap retracted nicely. This is another example of a case. This was a perforated ulcer in June 2020. This is courtesy, Dr. Nikun Stank and me, we were both managing this case together. Did a TB-cell, and then we did it at healed with vascularization. FND, fine needle diathermy was done. And then October 2020, PK was done. Then he had lute sutures with an infection and a hyperpion, infiltrated in a hyperpion. December 2020, he recovered after the removal. And May 2021, he was like this, and he was then being planned for a sclera fixated IL. So the trick over here in managing all of such cases is to be extremely patient. This is another example of a modified Gunderson's flap. This is when I was about to do a keratoplasty. So if you do it with a thick tenons, or even if you do a thick tenons patch graft, you can manage to save the eye in situations like this, as you can see. There have been literature reports of using a multi-layered amniotic membrane also along with fibrin glue, where you can tuck it, the fibrin glue, and with an AMT plug in the center of the perforation, then again cover with the amniotic membrane. There have been reports of using fibrin glue as well along with cyanoacrylate glue with this, but fibrin glue provides faster healing and induces significantly less corneal vascularization, but the strong adhesive effect is more with the cyanoacrylate glue. If you have access somewhere to a scleral patch or somewhere nearby from another institute, you can always take some donor corneoscleral rims and keep it up in glycerine inside your surface if you inside your institute or a hospital where you have access. So if there's a perforation like this, you can always do a scleral patch graft. This is another example of this case, again using a rim that was preserved in glycerine to get the desired effect. So in fact, during the COVID period, we had done a study to demonstrate the various methods of managing perforations in the pandemic area, where the primary outcome was the anatomical outcome after 3 months, and the secondary outcome was the potential for vision saving. And basically we had patients, and the protocol that I had shown earlier was followed. All parameters were recorded. What I would like to say is that 35 patients out of 112 underwent TABCL, 20 underwent modified Gunderson's, 31 underwent PK, and we used around 26 eyes from Cornisol and 6 from glycerine. And if you look at this, we had about around almost 90% eyes, we had an intact glow out of 112, and we managed to save basically around 80% of the eyes. So it is really gratifying if you can save those eyes. So thank you so much.
Thank you, Karan. That was really nice. And I guess something like cyanoacrylate glue, which is not very difficult, it should not be considered as a cornea surgery, something. A general ophthalmologist who can do cataract surgery can certainly apply glue, and which is not difficult thing. Sometimes we try to make too much of watertight compartments in our mind, and no cornea surgeon would be angry if you put a glue in a decent way. There are a lot of resources out there where they are shown how to put glue. To start with, Karan, how do you get the glue? How expensive it is, and what is the shelf life? The cyanoacrylate glue?
Pardon, sir?
How do you get the glue? How expensive it is, and what is the shelf life?
It's not expensive at all. It's about 500 rupees you get it, and maybe a little bit cheaper than that. So it's very easy, and you can get it everywhere.
Sure. So some of the places there are different such kind of glues available. Some of the places they use that Fevikwik, which is available in 5 rupees, but has significant amount of irritation and significant amount of vascularization, and it's not as nice to the surface. Having said that, the medical grade cyanoacrylate glue are available and they're not difficult. They have a significantly good shelf life. If you keep it somewhere in one of the pharmacies in your city, I think everybody can just avail it, and it's not a big deal. Learning to put glue can help you in many places, and certainly is something which we all should learn. Karan, you showed different materials like you used draped and all those things. Once you put such kind of thing, how long do you wait, and which is the next step of corneal transplant or whatever patch graft you want to do? How long you would leave like that, and when do you
If
revisit?
it's just a glue, I would start seeing after 1.5 to 2 months. Basically, what you have to see is it has to get loosened by itself, and always be prepared for a perforation in the OPD also if you manipulate too much. So it takes about 2 to 3 months for it to heal. If it's a large perforation such as a drape where I have put, so it is going to be stuck very nicely. So then that I have always felt it needs a keratoplasty later on to get that.
So not all the glues would require keratoplasty. Many times you would be very surprised that when it heals, there is significant amount of stroma which is there, and technically also that kind of eye holds on. So once the glue becomes loose or dislodges, and certainly you can reassess it. The bandage contact lens is not just for the glue to be there. Bandage contact lens is to make the patient comfortable. Glue has a very rough surface, and it can be very, very irritating to the patient and can erode the palpebral conjunctiva significantly. So to keep them comfortable also, bandage contact lens is required. Dr. Nikhil, if somebody has a perforation and you have availability of the tissue, like say a therapeutic graft, but very small area, and you have been showing us about small patch graft versus larger therapeutic graft, what would you choose and why?
No, one is that basically when we compare a glue with a patch graft, we need to understand that depends on the location of the perforation. So the glue heals with secondary healing, while if you put a patch graft, it will heal with much less of scarring and much less of vascularization. So let's say you have a central perforation, you put a glue, it will heal, but it will give rise to a very bad vascularized scar, which will be a high risk for a second keratoplasty. So in that situation, if it's a non-infective perforation or a sterile melt, you can do small patch grafts to tide over the crisis, restore tectonic stability, and also no vessels will be there. So subsequently, if at all a PK is required, you have a much better prognosis. So in many of the situations, especially when we have sterile melts, autoimmune melts, if they're in the even if they're in the mid periphery or they're close to the center, although glue may work, I think a small patch graft, sometimes even a lamellar disc of tissue, if you can put a few sutures, it will hold on there, and it will probably give you a better chance to do a more successful graft in the subsequent time, if it is needed, of course. If it's peripheral, of course, then you can get away without doing a PK later, and you can maintain the tectonic stability by just a small patch graft. But basically, I think when I started after my fellowship, I used to do lots of glues, but then I realized that if you do a small patch graft, it can work probably better in the long run, because you don't get all those vessels, and the things heal much faster. A glue may take, the healing time will depend on where the perforation is. If you have a sterile central perforation, glue may take 3 months. Once you put a patch graft or you put something like that, it will heal much faster, and it's more quicker to heal with.
Thank you. So that's, yeah, please go ahead. So that means that it also depends on the availability of the tissue in your hand. If you have tissue availability, then you reassess what is the best for the patient. Please go ahead.
So the T-node patch with overlay sutures, it works well in sterile corneal perforations. Have you tried it in infectious cases? I tried it in a couple of cases. It didn't work well in infectious cases.
So your question is infection?
The Tenon's patch with overlay
Tenon's
sutures.
patch.
Tenon's. Yeah. So Tenon's patch graft is again a very good option, which I think in the last few years we have been started or people have started using, and I think it's a good sort of option where again you can restore tectonic strength without probably getting a lot of inflammatory reaction, because it's a sort of tissue which will be more easily accepted. So I think it's a good alternative.
But in infective
Infectious.
keratitis,
Sterile, it works well. So we've been using it for 2 years.
No, in infection, I'm not sure. Like, if there is active infection, it may not work, or it may sort of, I don't know, it might cause the infection to get. I haven't used really for
Comes off, actually.
grossly infectious, I haven't used.
so the organism which is already there, the inflammation which is already there, it will eat it away. So it is not going to work.
So in that
So if it's an
case only.
infection, we have to understand whenever there's a perforation, look for the cause. What is an issue? And that needs to be taken care of. So whatever perforation we are dealing with, whether it is covering with the cyanoacrylate glue, multi-layered AMG, tenon, whatever, we need to understand we have to take care of the primary issue. So here the infection needs to be controlled, and here tissue adhesive, the cyanoacrylate glue works better because it attacks the vessels also, and which you need for infection resolution.
Thank you.
Hope that's clear. So
Also, the Tenon's patch graph, again, we do too much of separation that only Tenon's patch graph, only this thing. That's also not required. In fact, we can have mix and match of many things. I mean, I seldom do only Tenon's patch graph. I use my amniotic membrane, Tenon, sometimes glue, and many things at my disposal. So mixing and matching actually has its own advantage, and we surely can take advantage of those things. So before we conclude, I would request Dr. Nikhil Gokhale to tell us about next Keracon.
I think we missed the last physical Keracon and we had it virtual, but this time in December, I'd like to invite all of you here, and please share this message with your other friends as well. So in December, we'll have a physical Keracon, which is at Marriott, which is just next to the international T2 terminal. So we'll hope that all our cornea and general ophthalmologists who are interested in cornea, we all meet together and have a very good meeting there. Thank you.
Thank you so much, Karan. And with this, we come to the conclusion of this session. Thank everyone for staying back. I hope that this session was worth it. I thank all the speakers who made such fantastic presentation and make it really lively. I'd like to thank panelists also, Dr. Nikhil, and our president, Dr. Himanshu Matalia, who's working very hard to make the Cornea Society of India even more academically vibrant. And see you all on 9th, 10th, and 11th December 2022 in Mumbai again. Thank you so much.
Can we take a picture, sir?